Good afternoon. This is Extrapulmonary TB A to Z, presented by Dr. Kevin Winthrop for the TB program, Oregon Health Authority. We'd like to welcome Dr. Winthrop, and he will begin presenting now.
Okay, thanks for having me back to talk about extrapulmonary TB. I love talking about it. This is titled A to Z. I'm going to cover some bit about diagnostics and a bit about therapeutics around extrapulmonary TB, and really some of the challenges inherent to extrapulmonary TB. I have a number of cases to go through with you, or just several, but some illustrate these challenges quite well because it can be difficult to diagnose and treat. There's also new CDC treatment guidelines out, as well as diagnostic guidelines, so I'll highlight some pertinent aspects of those guidelines in this discussion. So, on to the next slide. So TB, just to remind you, in the upper picture there is a bunch of cells with little red snappers. Now, I'm colorblind, so this means nothing to me, but other people apparently can see those little red snappers. Those are TB bacilli. So what is MTB? Well, it's really a complex of species that includes MTB, which is the human pathogen, but also includes the human pathogens Bovis, Candida, and Africanum. These are causes of human TB. Of course, Bovis is also found in cows. M. microti is in voles, and Pinnipedii, you can probably guess, is from seals. There has been cases of human Pinnipedii, in whom, well, you guessed it, seal trainers. So it is a known risk of the job. Beware if you're a seal trainer out there. Modes of transmission, well, most people, of course, inhale the TB bacilli. There's some other more exotic modes. Probably the one to highlight down below on the slide is really the raw milk ingestion. This is a common way people are infected around the world, in places where milk is not pasteurized and where cows aren't screened for TB. This is a concern. So TB pathogenesis, the usual way is, of course, by inhalation. And when you breathe in TB bacilli, your alveolar macrophages rush to engulf those TB bacilli. Now, those bacilli actually are happy for that to happen. TB in the human immune system has co-evolved for millennia. And the bacilli want to be engulfed by the macrophages, and within the macrophage they actually replicate and eventually spill out of the macrophage and briefly disseminate throughout the body. And this is why we get extrapulmonary TB, because those bacilli will eventually be stopped almost always, not always, but at least with the initial infection. They typically end up in the middle of granulomas, really anywhere in the body. So at this point, there's this cytokine and cellular activation step where the immune system attempts to limit the spread of infection, and this is done primarily by granuloma formation around the bacilli, driven by TNF-alpha, and then intracellular killing of bacilli, which is a process primarily driven by interferon gamma. So in 90%, those granulomas and the TB bacilli associated with them remain in a state of really minimal metabolic activity. We call it latency, although it is active. It's just not very active. And for 10% of these individuals, this becomes a problem sometime later in life. So again, 90% have no problem, and the infection remains as latent TB. But again, in 10%, patients will develop disease, and we all know immunosuppression increases the risk of progression to disease. And when we're talking about immunosuppressed hosts, certainly extrapulmonary forms of TB are more common, much more common in immunosuppressed individuals than they are in seemingly immunocompetent individuals. So global TB epi, you've seen this before. The darker you are on the map, the higher your incidence and prevalence of TB is. Sub-Saharan Africa and Asia are notable. And then, of course, Western Europe and North America are notable for quite low rates. The epi curve in the U.S. continues to decline, although last year we leveled out. And if you look at this is really a historic low for our country. And the reason why, in my mind, this curve continues to diminish is that we have done a much better job the last 15, 20 years of investigating contacts and diminishing the spread of TB from cases to contacts through better CIs and more aggressive treatment of contacts. And we see this here too. It's the same explanation. And what this is CDC every year puts this out. This is their most recent data set in 2000, incorporating 2015 data. But you can see the blue bars is the actual number of TB cases in foreign-born individuals in the U.S., and that stays fairly stable the last 20-some years, although it's dropped off the last 6 years, 7 years. The green line that gradually rises across in diagonal fashion from left to right, that indicates a proportion of total cases that occur in the U.S. that are actually in foreign-born individuals. And you can see that figure is up to 2/3. It's almost 70%. And in Oregon, that's the same. In fact, it's slightly over 70% in Oregon, if I recall correctly. So by far and away, the biggest risk factor for TB in the U.S. is, of course, being of foreign birth. I just show this here to remind you that isoniazid resistance is quite common. It's about 10% of our cases overall. You can see slightly higher rates in the foreign-born individuals up top here, with about 11%, and the rates are more like 7 or 8% for U.S.-born TB cases, and overall, again, about 10%. So this doesn't necessarily influence your treatment choice, although it does make me think about treatment of LTBI, for example. Maybe we shouldn't be using isoniazid alone regimens, and probably combination regimens or rifampin-based regimens might be more effective, particularly in people who come from areas where there's even higher rates of INH resistance. So clinical presentation. So most TB is pulmonary, 75 to 80%, and the remaining is extrapulmonary. So 10 to 15% of TB tends to be extrapulmonary alone, and then 5% is really disseminated, and that means it's everywhere. With million chest radiographs, and I'm going to give you some visuals on all these forms of TB. In terms of extrapulmonary TB, lymphadenopathy, particularly in the neck, or scrofula as it's termed, is the most common. Bone TB used to be much more common. We see it less frequently now, and I'll get to some of these individual forms in a second. So CDC's latest data. So why do we know these things? Well, it's because you guys report them every year, and CDC aggregates the data. And from the last report, you can see roughly the same thing I just told you, which is the usual. About 20% of cases in red there are extrapulmonary, and then there's a certain percent that are both pulmonary and extrapulmonary, about 9.9%. So 70% being strictly pulmonary. In the second row or second table there, you have the sites of extrapulmonary involvement, with lymphatic being circled there and being the most common, 35%. And then pleural TB is probably the second most common, right to its left. It's 17%. And you can see other forms or sites of disease that are less frequently noted. All the way to the right is laryngeal TB. Of course, we always like to talk about the choir boy or girl with laryngeal TB who is singing their TB bacilli into the air, but it's quite rare. There was only 4 cases in the U.S. Last year. In terms of risk factors for TB, again, we think about immunocompromised states, and you can look at this row here. You can see diabetes, renal disease, TNF-alpha blockers, post-organ transplantation, immunosuppression. But what's circled there is really 44%. Really, almost half of the cases have no quote-unquote risk factors for developing TB, and I'd just like to point that out. So what is this? Well, it's a buttock. You're correct, a right buttock. And since we're talking about extrapulmonary TB, you should probably guess, oh, it's TB. Well, you're right. It is TB. TB of the skin is rare, but it probably accounts for 1 to 2% of extrapulmonary forms or sites of disease. This is also TB of the ear. These are areas where extrapulmonary TB has reactivated or progressed from a latent form to active form. This guy with the ear, this is someone who was thought to have eczema, and of course you put the steroid on repeatedly, it starts getting better, and then it gets worse, and eventually they biopsied it, and it was shown to be TB. This is not TB actually, but it occurs in someone with TB. It's called erythema induratum. It's distinct from erythema nodosum. So EN or erythema nodosum are red bumps like this on the front of the shin. This occurs on the calf, on the back of the leg. And it is common. It's an immune phenomenon. If you biopsy it, it would be culture negative, but it occurs in people with mycobacterial disease, particularly TB. So if you see it, it is a sign that perhaps the patient has TB elsewhere. This is just not good. There's no other way to explain this one. It's not the mumps, but it's testicular TB, and you can see this left testicle that's essentially very cystic and necrotic and heavily involved. This is a fairly rare form of TB, but again, GU TB does occur, and in males this would be a preferred site by the TB bacillus. So case number 1, I'll go through several cases to illustrate some of the challenges of these cases in terms of management. This was a 41-year-old female. She's Indian born. She had some sort of inflammatory arthritis. It was seronegative, meaning it wasn't RA, but maybe it was going to be RA. They didn't really quite know. She was put on prednisone and hydroxychloroquine, HCQ. She got better, and then 1 year later developed back pain, which eventually was worked up, and she's found to have this discitis on imaging and an associated abscess. It was drained, and it grew out MTB. It was pan-sensitive. She was put on 4-drug therapy for 2 months. And then she was switched to INH and rifampin alone for 10 months. However, she had this persistent abscess on imaging. It had been about 12 months now. You can see it here anteriorly on the left, or pick an image. You can see the same thing in each image, but you see this defect in the vertebral body, in the space between these two vertebral bodies. And this is an area of osteomyelitis and discitis. And then on the lateral view, you can see on the left-hand image a lot of gadolinium enhancement here, indicating this is active, and this is fluid that is just highly inflammatory. What was interesting too is that she was noted to have on her pelvic MRI several psoas abscesses. So if you look on the right-hand image, it's probably most easily seen. You can see the muscle to the right of the vertebral body, and inside that muscle is a circular lighter area, which is the abscess. And that abscess tracked from L2 all the way down through the psoas muscle. And on the right side, or actually the left side of the image as you're looking at it, you see a similar formation in the psoas musculature there. So she had these bilateral psoas abscesses. So it'd been 12 months. People weren't really sure what to do with her. They rebiopsied her L2, and it was, I believe it was smear positive, but it was AFB culture negative. And she ended up going to India to get a consult from a TB expert there. They recommended she just be put on like 7 drugs for MDR TB treatment. She was not as excited about that. I don't blame her. She came home and talked it over with people here, and she was changed to daily INH and rifampin, and the decision was made to keep treating. So she then took another 6 months of therapy, and at 18 months she was re-imaged, and she still had these fluid collections, both in the bilateral psoas abscess, psoas musculature, as well as around L2. She had really no symptoms. She felt great except for some chronic low-grade back pain. So the question is, what are we doing? And are we treating still? What are we treating? And can we stop treating? So this was some repeat imaging, and it's hard to see, but these abscesses in the psoas musculature have continued to shrink. And at that point, they were slightly smaller, but really not a whole lot. And the back looked, her discitis looked very similar, with maybe a slightly less enhancing area of fluid collection. So I saw her and decided that, these are probably sterile abscesses, which was suggested by the biopsy 6 months earlier. And it's probably iris-like phenomenon, immune reconstitution inflammatory syndrome, that individuals will develop these sterile cold abscesses, and sometimes it takes a long time for those abscesses to resolve. I would not go in and cut these out. I think if they grew, then of course rebiopsying them to see if there's some active infection would be the thing to do. We did stop her therapy, and we've re-imaged her at Q3 month intervals for the last 6 months, and these areas have remained stable or have slightly shrunk. So she's been off therapy now for 6 or 9 months, and I think she's probably home free. I think, again, these are just residual fluid collections, and they will, if you took them out, they probably would look like Swiss cheese. So they'll gradually scar down, but she'll probably always have something there. So here's another case, and this was a case too of IRIS, or immune reconstitution inflammatory syndrome. Very sad case, because the irony is deep here. He is a skier, a big skier. In fact, he worked on the U.S. Olympic team as a ski tech, and he worked for the Paralympic team, supporting para athletes. So he had PSA, or psoriatic arthritis. He was on a TNF blocker. He went to Sochi to the Winter Olympics a couple years ago. He got home, and 6 months later his wrist was swelling. The thought was his psoriatic arthritis was out of control, but he was having night sweats and weight loss. You can see the CT imaging of his hand here. The little bright circles are the bones, but you can see all this diffuse grayness between the bones, and this is just all swelling and fluid, and eventually there was some abscess in some of these areas. So he was started on adalimumab. He wasn't necessarily rescreened for TB because he'd been screened before. His constitutional symptoms worsened. He blew up an abscess at the thumb. He developed a cough and back pain. Eventually he was re-imaged in his chest. It looked like he had pulmonary TB. His sputum grew TB. He developed an epidural abscess, and he had that drained. It also grew TB. So he was classified as someone having disseminated TB because it was actually at this point lungs, spine, and both hands. So he was treated with 4 drugs. He started 2 or 3 months into therapy, really worsening clinically in terms of developing these recurrent abscesses at multiple levels in the spine, C6, T2, T6, T8, etc., several other areas as well. He had multiple drainage procedures and laminectomies done there. He had a recurrent abscess in his left thumb. Over the next 6 months, again, more and more abscesses. Right hand, one of his fingers, several other areas, both similar areas as well as new areas along the spine. All of these were drained. All of them were culture negative. Some of them were smear positive, but again, all of them were culture negative. My interpretation of this is again, this is immune reconstitution, inflammatory syndrome, and just cold abscesses. So here's some imaging here. You can see obliteration of the disc space and inflammation here along the spinal canal. He was started then on 60 milligrams of prednisone. I think this was my recommendation. I thought, well, we got to immunosuppress him. He can't, we've got to stop these abscesses. Despite this, he still continued to abscess through this therapy and had multiple recurrent abscesses, again requiring drainage. Again, they were all seronegative. So then in consultation with his treating physicians, we decided to restart his TNF blocker, and we started Tanacept, thinking it has slightly less robust TNF blockade than other ones. Maybe it's safer. So we started that and started weaning his prednisone, and again he developed another abscess. This was also a sterile abscess. So we put his prednisone back up. We stopped his etanercept, and we started adalimumab, a more robust or strong quote-unquote TNF blocker. He stayed on INH and RIF, and eventually his abscesses stopped after this. Unfortunately, he was left as paraplegic, and I think he's probably regained some function since that time, but I haven't seen him in a year, and it was really it was just a sad outcome of a bunch of sterile abscesses. I mean, it's just like we could not get these things to stop recurring. So now he's still on adalimumab. We stopped his TB treatment at 12 months, and I think that's one of the points of this, is that after a while, probably there's no benefit to further TB therapy, and so we stopped in 12 months, which would be the usual stopping point for a bone infection, 9 to 12 months. Particularly, we felt comfortable with this given when we kept demonstrating the abscesses were sterile. And again, there's his imaging with quite a bit of fluid collection and obliteration of the disc space there. So are they always this difficult? No, they're not. So 6 months of therapy for most, 9 to 12 months for bone and joint. I just presented 2 joint cases that were really with prolonged inflammatory consequences and iris-like phenomenon, and both of those were either stopped at 12 months or probably could have been stopped at 12 months. And then for CNS TB, of course, 12 months is the standard. Here are the new diagnostic guidelines. There's a similar title for or a similar heading in the CID journal, Clinical Infectious Disease Journal, for the treatment statement. I think from the treatment statement, really one of the most important take-homes was these 2 PICO questions. PICO, these are, I can't remember what PICO stands for. It's kind of a miserable experience on guidelines committees these days. We have to come up with our top 10 PICO questions and write them down, and then or 15, however many questions were allowed. And then there's these systematic reviews around each question. Many times there's not much literature to inform the answer, and we end up with these very conditional recommendations with low levels of evidence and really low levels of certainty, which is basically just expert opinion. So that's kind of what happened here with PICO question number 7. Does the use of adjuvant corticosteroids in TB pericarditis provide benefits? And there really wasn't a whole lot of data here, but there was some, and that data really suggested that the answer was no. For pericarditis, you don't need to start them right off the bat, but you could consider them later as the patient goes through their course if they start developing signs of constriction. PICO question number 8 was with TB meningitis. Here there was a lot more evidence, and the evidence was positive in that really there was good evidence that dexamethasone or prednisolone used empirically in the first 2 months does, or not empirically, but just used right off the bat in the first 2 months does decrease adverse sequelae of meningitis. And you can see my text here at the bottom of the slide. So think steroids really right off the bat for CNS TB, including sometimes ocular TB. If vital structures in the eye are threatened, we often have to use steroids right away. So there's 2 IGRAs, as you're well aware of. They can be useful in diagnosing extrapulmonary TB. Our diagnostic toolkit is really from top to bottom. A priori probability I always think is the most important. Does the patient have a history of positive screening tests? Do they have a history of contact? Should they have TB? Those kind of questions. AFB stain is really poorly sensitive. Culture, of course, is the gold standard along with molecular techniques, both PCR and NAT. IGRAs of peripheral fluid can be done. We do that in plural cases. We've done it in CNS. And those, of course, are experimental uses of the IGRA, but there's plenty of case reports in the literature attesting to their potential benefit in making a diagnosis. ADA, adenosine deaminase of pleural fluid, is actually relatively sensitive and specific for pleural TB, and the time or the turnaround time for getting one of those has dropped in the last few years, so it is a pretty useful test, so I always order it. And then, of course, histopathology. Sometimes people forget to send things for path, but of course, if there's granulomatous pathology, it does raise your potential that TB is potentially there. So this was a case on the left hand of that slide. That's a right knee that's completely destroyed. You can see all this loss of joint space. You can see a ton of bone on bone and really sclerotic bone reaction, lots of white in there. This woman then underwent a joint replacement. You could see this nice new hardware in there and a really nice joint space. She was much happier. However, 3 or 4 weeks later, she started draining out of this fistulous tract, and this was cultured several times over the course of several months. It was always culture negative. Eventually, her doc thought, well, maybe she's from India. Maybe we should think about something beyond staph, etc. And they sent her for AFB culture. On the right-hand side was just a picture of the pus that was cultured. Bottom line is she grew out MTB. So the case did raise some questions. What do you do with the orthopedic hardware? And if this was staph, or if it was non-tuberculous mycobacterium, or really any other infection, you've got to get the hardware out. You're just not going to cure it. A lot of those bugs, like the biofilm, associated with the hardware, and it's impossible to cure unless you take the hardware out. TB, I think, is different. There's a number of case reports in the literature attesting the fact that you can leave the hardware in, That's what we did in this case, in collaboration with physicians in India, because she halfway through ended up going back to India. But 9 to 12 months of treatment, I think veering towards 12 months if there's hardware in place makes sense. And then occasionally surgery, particularly spinal TB. I showed you those cases. If there's cord compressions or symptoms, spinal instability, etc., then surgery is likely imminent. Let's talk about scrofula. So in kids under 5 years in the U.S., this is more likely NTM than it is TB. MAC is a common cause of cervical lymphadenitis in kids. And again, if it's mycobacterial in origin, it's much more likely to be MAC than TB. Now, of course, think about your epi. If this person's from Peru, then that may be opposite. It may be more likely to be TB than NTM. But certainly a U.S.-born person, I would be favoring NTM as a diagnosis. You can use an FNA. They're often non-diagnostic. That's a fine needle aspirin. But a surgical excisional biopsy of the node involved will give you the answer. Here's a case of scrofula TB. You can see at least 4 very large necrotic nodes in this individual. She was draining out the side through a fistulous tract. Actually, we just cultured the fistulous tract, and it was smear and culture positive, so she did not undergo excision. She underwent therapy for 6 months, was completely cured. I will say that individual on 6 months, when she walked in for an end of therapy visit, her neck had blown back up on her in the last 2 weeks, and so I had it biopsied. It was culture negative. Again, this was similar iris-like phenomena that I've described earlier in the talk. Cold abscesses. I treated her for 3 more months for good measure and then stopped. Anyway, just be ready for it because it can happen. But generally 6 months of therapy is adequate. And probably had I stopped her then at 6 months, it would have been just fine. But I wasn't sure what her culture result was going to be, so waiting that 6 to 8 weeks for cultures, I ended up just rounding it out to 9 months of therapy. Pericardial TB, I already kind of mentioned. 6 months of treatment is standard. Adjunctive steroids, there was one RCT that showed really no difference, and that formed the CDC's guidance or answer to that PICO question. The last bullet there, the caveats, of course, is those with early constriction or a lot of inflammation with large effusions. You could think about using steroids. Renal TB, you can see on the left the arrow points to all that blackness on that kidney. That's in a large necrotic abscess kidney. And on the right, you see a similar kidney, although it's not as black. You also see the arrow towards the center pointing at some enlarged lymph nodes. So renal TB, or really any aspect of the GU system, the genitourinary tract, 6 months of TB is a standard. Sometimes you need to drain these abscesses, particularly if there's hydronephrosis or renal failure. Again, if there's renal failure, you're going to need to dose adjust some of your meds, PZA, ethambutol, and levofloxacin if you're using a fluoroquinolone. And sometimes large tubo-ovarian abscesses might need to be drained as well. But generally, medical therapy is adequate. You can see this. This is a nice TB empyema, and this has just got to come out. It's not going to heal. You can see all the you see the arrow pointing toward the empyema. The darker the darkness there is really abscess cavity, and there's that thick rind around it of inflammatory tissue. And then just to the north of it in the picture is really just atelectatic lung. Now, you could have infiltrated that lung too. Maybe there's some pulmonary involvement. I would definitely get sputum or respiratory samples to rule it out. But I think in this case it was just atelectasis, and this was really pleural TB. By definition is extrapulmonary TB, and you have to decorticate this, so surgery is really the treatment of choice. No routine use of corticosteroids. TB empyema, surgical drainage, just as I said. And this is a classic chest x-ray of miliary TB. You can see all those little fine, tiny dots everywhere. 6 months of treatment is usually adequate. If you think there's CNS involvement, either by imaging or clinically, of course, if clinically they're acting like they have CNS involvement, then they should be tapped and imaged. So sometimes you extend these people to 12 months, but generally 6 to 9 months is adequate. So CNS TB, TB meningitis, 12 months of therapy. We often add a fluoroquinolone, that's the FQ there in the second bullet, just because it penetrates well into the CNS. Many people can have complications. There is high degree of mortality associated with this. Corticosteroids decrease that mortality, and they should be used the first couple months. Ocular TB, the beauty of ocular TB is it can look like absolutely anything. That's kind of true of TB anywhere, but I could show you about 15 pictures of different presentations in the eye of TB. The upper right there, you can see all these little white chorioretinal lesions. These are little areas of infiltrate where TB bacilli is active. On the lower picture, you see what's called a hypopyon. You see that layering of pus at the base of the cornea there, and you can see that the cornea, the inside of it, is also splattered with little white snowballs of pus. If you can get a specimen, that's great. A tap of the anterior chamber or a vitrectomy, send it for PCR, but it's very unusual to talk an ophthalmologist into doing this, particularly getting specimens from the front part of the eye are just so small, the diagnostic yields very little. From the back of the eye, the risk is just too great in terms of vision loss, retinal detachment, etc. Now, if they already have substantial visual loss, or if they're already doing a vitrectomy because the retina is detached, then go ahead and collect that vitreal fluid and request that it gets sent along for testing. Treatment is variable. We surveyed all these experts around the world a couple years ago. People are treating between 3 months and 12 months, and it was kind of equally split between 3, 6, 9, and 12 months. I mean, there's really no consensus, and I tend to treat for 12 months if it's in the back of the eye. If it's in the front of the eye, I will generally stop at 6 months, but oftentimes it's in multiple areas of the eye, and I tend to drift towards 12 months. So why is my eye watering? This was a woman from Peru. She came in with this constant epiphora, which is the ophthalmology word for a watery eye. And the arrow pointing there is to a thickened nasolacrimal duct there. This is the duct that drains tears from the eye into the nose. This is a picture of what it would have looked like. This is a different patient. I didn't have a picture of the real patient of which I'm speaking. But you can see G and the arrows there pointing to these granulomatous masses there. They're constricting that canal and making it harder for tears to flow through it. 3 months later, after her biopsy of her nasolacrimal duct showing granulomatous inflammation, she developed these 2 necrotic lymph nodes just below that duct in her neck, and these were biopsied and found to have TB. So she had reactivated TB in her nasolacrimal duct. It had drained into her regional lymph nodes, and she had scrofula diagnosed, and she was treated for 6 months and did great. So that's probably it in terms of my overview of extrapulmonary TB, and I'd like to acknowledge all my friends here at the health department and elsewhere with whom I collaborate, and happy to take your questions at this time. Thanks very much.